Hi, and thank you for joining our educational webinar with Dr. Nirav Patel, who will highlight a number of hip and knee conditions and how they can be treated, including joint replacement surgery. My name is Sharnese Smith, and I'm a member of VCU Health's marketing team. So before we begin our presentation, I'd like to first make note that we'll hold all questions until the very end. So please feel free to drop your questions into the comments section, and we'll address them during the Q&A. So I'd like to introduce our speaker tonight, Dr. Patel. He treats conditions of the skeletal system such as the hip and knee arthritis, cartilage problems, ligament tendon injuries, and problematic joint replacements, along with the hip and knee pain in general. His patients come in from the form of young people with injuries to middle-aged individuals dealing with joint pain to an elderly person who took a tumble or is living with debilitating arthritis. Dr. Patel's research interests include enhanced recovery after joint replacement, cartilage preservation, opioid-sparing surgery, joint replacement after sports injuries, and the process of returning to sports after injury and surgery. In addition, Dr. Patel has also served as one of the team physicians for the Philadelphia Eagles during their Super Bowl win, as well as the 76ers, the Phillies, and the Flyers. Thank you, Dr. Patel, for joining us today, and I'll now turn the show over to you.
Thanks, Sharnese. Welcome, everyone. As Sharnese mentioned, my name is Nirav Patel. I'm one of the surgeons at VCU Health. I'm a specialist in hip and knee reconstruction, preservation, and replacement. And today I'm going to talk to you a little bit about my practice and perhaps making a decision about hip and knee replacement and other surgeries, and hopefully give you some insight into these and also take some of your questions at the end. So I'll get going. This is a brief overview of what I'll be talking about today. The knee, I'll look at the anatomy, talk about arthritis or osteoarthritis or wear and tear, ligament injury or meniscal injury, the shock absorber, the cushion in the knee, and cartilage injury. And similarly for the hip, with some arthritis information, some information about impingement, also known as FAI, as well as to a degree tendon disease and some bursitis and other causes of pain and dysfunction. Next slide. I'd also like to cover what can you do if you have some of these symptoms or injuries, and some new technologies that I often get asked about and are on the horizon. Next slide. So the anatomy of the knee, I'll keep it very brief. There are essentially four bones, notably the thigh bone and the shin bone and the kneecap or the patella bone. Also, there's a smaller bone called the fibula. Four ligaments. You may have heard the ACL, the PCL, the cruciate ligaments, also the collateral ligaments, the MCL and the LCL, as well as two types of cartilage, mainly the surface, and also the meniscus or the shock absorber, the cushion in the knee. Next slide. Osteoarthritis affects many Americans, as you can see there, over 40 million. And this is known as wear and tear. And if we see the knee as a car tire, then it's the tread wear or the surface lining of the joint that wears down, causing pain and dysfunction. And many more people are projected to have osteoarthritis in the future. All races are affected equally. Women slightly more than men, and it tends to occur after the age of 40 predominantly, although it increases with age. It does increase in the face of obesity, and almost 500,000 knee replacements are performed a year, and another 500,000 joint hip replacements, giving rise to 1 million joint replacements per year in the US alone. Next slide. This is just a follow-up of the tread wear that I was talking about, and the surface of the joint you can see is worn away, a bit like the car tire analogy. And when that surface is worn away, it should be smooth like the bottom left image there. That rough surface can catch within the knee, cause clicking, popping, pain, swelling, and very much limit your activities. Next slide. Osteoarthritis depends, as I mentioned earlier, on age, whether there's been a history of injury or trauma. I see a lot of current sportsmen, but also previous sportsmen and women. There may be some inflammatory conditions such as rheumatism or rheumatoid arthritis. And there tends to be classically pain with use, but also stiffness. There may be some grating or catching. And I tend to ask about how much you can walk. Is there pain at night? Because that's particularly a problem for patients. And whether you've had any previous treatment. I also like to always get x-rays, and we get these in the office when you come. I get specialist knee views in addition to the standard view your primary care or the emergency room may obtain, and sometimes an MRI, although unlikely if I can see the diagnosis on x-rays. Next slide. This is an example of an x-ray of a knee. On the left, you can see a healthy knee, and the knee is a hinge joint and it bends across the gap that you can see across the center of the image. And if you look towards on the right side where it says bald tire, that gap is lost, and that gap is cartilage that we lose after the age of 40. And this is severe or bone on bone, but there are variations of wear and tear. Next slide. In terms of treatment, I use a ladder approach, hence the ladder, but my aim is to make your life better by reducing your pain, number one, improving your motion, increasing your strength, and we go in a stepwise formation, with surgery being the last or the top rung of the ladder. Next slide. The first one is very basic medications, and surprisingly, a high dose Tylenol, 1,000 milligrams up to 4 times a day, can help and keep a lot of my patients' symptoms at bay. You can then move on to anti-inflammatories. Ibuprofen is one of my go-tos, certainly, but also vitamins and nutritional supplements have been shown to potentially have some impact, such as glucosamine and chondroitin, although not definitively a treatment per se for arthritis. You can take fish oil, and a good healthy overall diet is always a good thing, as well as some alternate therapies such as yoga, tai chi, and acupuncture, which have shown to help patients. In general, I would say if alternative medicines and treatments cause no pain and you can afford it, then I think it's reasonable to try. Next slide. The next rung is injections. I offer a whole host of them. I usually start with cortisone, which is a steroid with some local anesthetic like a dentist injection. And that's, you're in and out within 30 seconds to a minute in terms of how long it takes me to do it, and back to your normal activities, low risk, and works well. Beyond that, certain insurances will allow viscosupplementation or gel or lubricating shots, which I also provide. And now more recently, I use this with the Eagles when we used PRP injections for the professional athletes, and now it's rolled out to all my patients. It's currently out of pocket, but it's basically where I spin down your blood and inject it back into your joint. And I'll come to that in a few more slides. But generally, it's safe and effective, and very little risk, if any. Next slide. I tend to say 3 injections per year maximum, and no less than every 3 months. Too much injection or steroid in the knee, what you think is not a good thing, and it's usually best when the knee is particularly inflamed because it works well. And I tend to say just ice it down the first day and take it easy, but after then, no restrictions. I am cautious with my diabetic patients, and I'll do 1 joint at a time because it can raise the blood sugar level, and it does sometimes give relief for many months. The way I do it with the knee hanging off the edge of the bed, like I said, it doesn't take me long at all, and actually it's often pain-free. Next slide. These are the gel injections or the lubricating injections, and these are the building blocks of cartilage, certainly sold as the cure to arthritis by pharmaceutical companies, and that's not the case. It tends to work in about half of my patients, but sometimes it can provide that bit of long-term relief that you need, more than a cortisone injection, either as a single shot or a series of 3, depending on your insurance. But it tends to work best for more mild to moderate disease rather than severe osteoarthritis. Next slide. And this is the new treatment that I'm offering, and it is now gaining data We know that it can help in hip and knee arthritis for up to a year, sometimes beyond. I've used it in professional sports personally. Minimal risk because it's your own blood. I spin that down and I inject the good platelets and the proteins and the growth factors into the knee to act as an anti-inflammatory agent, but also theoretically regenerating, my apologies, regenerating agent within the knee to help reduce the pain and swelling and help improve your function. Next slide. I always start with a non-operative treatment program, and these are some of the non-operative treatment measures I've already discussed, but a daily home exercise program with stretching daily and strengthening the other days, 3 times a week of low impact exercise is a long-term game to help keep the symptoms of arthritis at bay. Physical therapy, next slide, is often underused and can cause some patients pain. So not always popular amongst my patients if you have arthritis. But I think a good therapist will provide a custom physical therapy program. And I have a whole list of therapists that I use that I trust that will get you through the strengthening and stretching program that you need for your painful joint. And allow your symptoms to be kept at bay and reduce the risk of them coming back. I usually suggest a 6-week course, at least 2 to 3 sessions a week if possible. But if you're busy, then at least allow the therapist to show you how to do the exercises and then perform them at home. The main thing is that it allows you to maintain your range of motion if possible, strengthen those muscles to offload those painful joints, and potentially delay surgery. My patients undergoing knee replacement surgery in particular do better having had physical therapy beforehand, and this has been shown in the studies too. Next slide. I would use braces a lot. I used it when I treated the professional athletes, but also in patients of all ages and all sizes and all activity levels. And it can be from a simple sleeve that improves your balance and proprioception, which is feedback to the knee, but also other more sturdier braces, such as a hinge knee brace. Or sometimes if arthritis is located to one part of your knee, such as the inside most commonly, then an offloader or an unloader brace can realign the knee and allow you to function or work or go hiking and other activities temporarily. Next slide. Other things to always talk about are walking aids. No one wants to use a cane, and I completely understand that's not very popular amongst my patients, but sometimes it can get you that extra few yards that you need to get around the grocery store or out walking with your family. I mentioned low impact exercise. My favorite is swimming, cycling, and elliptical. Difficult in the face of COVID at the moment. I appreciate that, but certainly they're the best ones to keep your symptoms at bay and prolong the lifespan of your joint. Weight loss is important, and I provide dietitian driven advice to all my patients with advice to go to a VCU weight reduction clinic if necessary. But certainly I'll be proud of my patients, and they all know this, even if you can lose 1 pound, that's 3 to 4 pounds less on your painful joint in terms of the load. And nowadays there is a cutoff when we look at body mass index or BMI in terms of safety for surgery, and our patients have to achieve a BMI of less than 40 to have surgery at VCU and most centers now across the US. Next slide. Surgery is top of the ladder, as I mentioned, and keyhole surgery is not really for arthritis, unlike the old days. And I was trained in this as in the UK, but also the US, where you can wash the knee out, but we know that patients don't always do well. I will consider it if we've tried every other treatment, but the arthritis can't be reversed with keyhole or arthroscopic surgery. So that means joint replacement or joint arthroplasty, and I do the full variety of replacements, and that could be partial, the inside or the outside of the knee, sometimes the kneecap, a total knee replacement, for example, which is the most common commonly done procedure for knee osteoarthritis, and then, as I mentioned, the kneecap replacement. I tend to try and avoid replacement surgery in those less than 50 years of age because the revision or redo rate is higher, and we are living to 80 or 90, and there's a likelihood this may need to be redone in your lifetime. Next slide. Partial knee replacements, usually, as I mentioned, as the picture on the left shows, arthritis on the inside of the knee there, between that thigh bone and shin bone, and then the replacement on the right. There is a smaller scar, faster recovery, less blood loss, and patients can return to sporting activity potentially sooner. The thing is, they do work very well for the first 10 years. We know that, but beyond that, then the rest of the knee tends to catch up and it needs to be converted to a total knee replacement. Next slide. This, like I mentioned, half a million of these are done per year in the US, tends to be for moderate or severe osteoarthritis when we've tried all the other treatments I've mentioned and nothing is working. It's a bigger procedure and you're in hospital for 1 to 2 days. The success rates are good, 80% or so, although 20% are not happy, and we still really don't know why this is the case. That's 200,000 people in the US alone per year. But I do my best to get you in that 80%, and if that's the case, we're hoping that this knee replacement will last 20, 25 years, if not more. Next slide. This is an example of the total knee replacement looked at from the side. It's a combination of cobalt, chrome, and titanium alloy with ultra-high molecular weight polyethylene in between. Next slide. And this is a picture of a knee replacement that I have put in the knee. A little gruesome, so apologies for that. But you can see the joint has been removed, and we'll sew that up, and hopefully the patient will do well. Next slide. Custom knee replacements are available, more and more so in the US, and now we're moving towards robotics too. Custom is basically a knee replacement that's made based on a CT scan or sometimes an MRI scan. In this case, I have been trained in performing these, where the cutting blocks, i.e. the cuts I make on your bones, are done based on customized cutting blocks, and then a customized knee replacement is placed. We know that these don't make any difference in the long term to patients. As long as a surgeon is competent and does a good job, then this versus a traditional total knee replacement makes no difference, but certainly is available. Next slide. And revision or redo surgeries is something also I do, usually they tend to be for loosening, for knee replacements or hip replacements done 15, 20 years ago, sometimes even more recently if there's been a problem. Infection, instability or the knee giving way is also a problem, and these are challenging surgeries that not all surgeons will do. We're proud to say at VCU Health we take patients from all over the state and sometimes out of state because the risks are higher for the patient, the outcomes are not as good, and it is harder and longer to rehab from, but there are solutions available for patients. Next slide. This is an example of a revision replacement with wear of the plastic component on the left-hand side knee. Sorry, the right-hand side you can see, but you can see it's on our left, and that's changed over to a long stemmed revision or redo knee replacement. So much more hardware and a bigger deal, certainly. Next slide. Meniscal injury, I did touch on it earlier, and it tends to be very localized pain for patients, and pain with squatting down, and there can be some locking or giving way sometimes as well. The swelling after an injury can be more gradual in onset. I certainly will take a thorough history from my patients, do a thorough physical examination, and then get x-rays, as I mentioned. An MRI is really what we need to diagnose. Certainly if there's not much arthritis there, then to look at these soft tissues, the cushion within the knee, and then plan treatment. Next slide. As I mentioned, I try and avoid doing arthroscopic surgery or surgery with a keyhole or a camera for arthritis. we don't really do the cleanup, but if there are loose bodies in the knee, I can remove these. But ideally, the patients that do best are a meniscal tear without any other problems within the knee, and they're getting mechanical symptoms, i.e. the knee is really locking. Often a doorstop in a door and the door getting jammed up. And I can remove that or repair it if possible in the younger patients. And the recovery is very fast, and patients are often back to work within a week or two, but 2 weeks for the wounds to heal, and you're in and out of the hospital on the same day. So it's outpatient surgery. Next slide. This is an example of meniscal surgery. And like I said, it takes 15 to 30 minutes or so to do. And there's a camera that's introduced into the knee. And I use various instruments to either repair or trim the meniscus. Next slide. And outcomes are good. As I mentioned, 80 to 90% patients are satisfied and returning to sports. But it can increase the contact stresses within the knee and theoretically wear out the knee prematurely. So I think it's important to take only the minimal amount necessary from the knee and repair if possible. Next slide. Cartilage injury tends to affect younger patients, and they tend to have very specific symptoms of clicking, locking, and pain and swelling. X-rays are certainly important to make sure there's no bone involved. If not, then an MRI is the next diagnostic regime. Next slide. And surgery, we have various options. It can vary from simple shaving down the cartilage to smooth out the flaps. You can see on the top right image there's a rough surface there of cartilage wear and injury. Sadly, we can't replace the cartilage that we are born with, but there are options to try and regenerate it, although they don't work particularly well. An old option that I still offer, because it can help, is microfracture, where you drill holes into the bone, and the cartilage is more of a scar type cartilage that can grow and fill in the hole at the bottom there. Next slide. And there's the drill holes into the bone. Next slide. We also do cartilage plugs, and the cartilage can be taken from the healthy part of your knee that you don't need, or a cadaver or donated plugs, or synthetic now, although the outcomes are not as good. But short-term outcomes for the other ones certainly are. More advanced techniques are where we take a sample of your cartilage. That's a small image, I apologize for that, but essentially ACI or MACI is where cartilage is grown in a lab, your own cells, and these are harvested, and then we go back in, open up the knee, and put the cartilage back into the defect. And it's a long recovery with bracing and therapy, but certainly have some reasonable outcomes there. Next slide. And that's just a picture of the cartilage plugs at the top left, and then the plug filled in on the right. Next slide. Moving on to hip. This is some hip joint anatomy made up. The hip is a ball and socket joint. It's made up of your pelvis, or the acetabulum specifically, and the femoral head, which is part of the ball, and that's your thigh bone. And there's an important tendon called your hip flexors, and one of those is the iliopsoas tendon, which flexes up the hip, but also a bursa, which is a fluid-filled sac that sits outside the hip joint, or the hip bone, in fact, can become inflamed and symptomatic. Next slide. Hip pain can affect patients of any age, but tend to be increasing in those who perform sporting activities, but also with age, if it's arthritis in particular, particularly after the age of 40. After an examination, I always obtain x-rays to include your whole pelvis, and I check your other hip too, because it's a good comparator for the painful hip. Sometimes a CAT scan or a CT scan, less needed for me, unless I'm looking for something very specialist. And an MRI in the younger patient in particular, sometimes with dye injected into the hip to look for those soft tissues. Next slide. Arthritis affects the hip just like as it does in the knee, and this is an x-ray of a ball and socket joint, you can see, and the normal space between the ball and the socket. And then on the right, you develop bone spurs, you lose that joint space, and that's the process of osteoarthritis. In extreme cases, I call it a Charlie Chaplin walk because patients have flexed hips and knees and their feet turn outwards, and you don't often see that so much nowadays because we intervene earlier, certainly in the Western world. But severe arthritis tends to be treated best at the end with a total hip replacement when nonoperative treatment fails, similar to the knee. Next slide. Medications, we start with the Tylenol, believe it or not, but quick to add in anti-inflammatories as we need them. Therapy is also very important to strengthen those muscles. Your core in particular, and your buttock muscles are often forgotten, and your back can take strain if your hip is unhappy, certainly, because it has to work harder. A walking aid, usually cane on the opposite side, and a cortisone injection either under ultrasound, which is something I have started to offer myself, but also x-ray guidance, which the radiologist can do, or I can certainly do in the OR or the operating room. Next slide. Total hip replacement is the definitive solution here for severe arthritis where everything else has failed. There are different approaches that I've been trained in terms of hip replacement. My go-to is the posterior approach because my patients do really well with low complication rates. I use certainly for the knee as well, we use regional anesthesia, so you're not put to sleep and have all the side effects of medications. 99% of my patients go home the next day, and often many want to go home the same day. You have therapy and you're up and walking the same day. And this, like knee replacement, you need to be in pretty good health, but we take patients of all backgrounds and all medical conditions at VCU, and we optimize you to minimize your risks, such as infection, which can be a disaster. And the outcomes are much better than knee replacements and not often known by my patients, in the region of 90 to 95% success rate, and they last a similar amount of time. Next slide. In preparation for a hip replacement or indeed a knee replacement, we send all our patients to preoperative assessment with anesthesia, so you get to meet them early and they get to intervene with your primary care and your cardiologist if necessary, and all the other providers, to minimize your risks. Certainly for knee replacement, I prefer all my patients to have physical therapy, which is called prehabilitation, to improve your outcomes, and that is well known. You go to joint school, so you meet all the team members, you know exactly the process to undergo. The days of the black box where you just show up for surgery, you don't know what's going to happen, are long gone now with joint replacement surgery, and you can ask questions throughout the whole process and know exactly, if you want to, that is, what will happen. I provide nutritional supplements and zinc, iron, and vitamin C for all my patients for 30 days prior to surgery, to try and build your immune system, particularly useful in this COVID-19 era. I also like my patients to see a dentist beforehand because any infections there should be treated before, so we don't have any issues afterwards. And it's all about reducing your risk, and I'm proud to say my risks are extremely low, if not 0%, and I work as a team to try and achieve that. Next slide. A total hip replacement is shown here, and it's a ball and socket joint, and it's made again of predominantly titanium, cobalt chrome alloy, sometimes titanium, and either a ceramic or a metal head and a plastic liner. And the recovery is certainly much quicker than a knee replacement, and my best patients, sometimes against my advice, are back to work at 2 weeks, back in the gym at 4 weeks on the elliptical, and sometimes even running, although my preference is low impact lifelong. And it's still a 2-year process for recovery, although much of that is done very early on. Next slide. Revisions or redos similar to the knee replacements, it's becoming a reality, and as I mentioned, we get referred patients from all over the state and beyond to redo these from implants done before, because patients are living longer. And as I mentioned, the risks are higher, the outcomes are not as good, and they don't tend to last as long, so we're very careful and prepare carefully to reduce the risk and do a good job, hopefully, for you and all the other patients. Next slide. I'll touch briefly just on some femoral acetabular impingement, not so much in detail today, and this is a busy slide, but basically this is where the ball impinges on the socket and it can cause difficulty with flexion. It can cause popping or the hip giving out. Tends to be in the younger patient that does not have arthritis. And it can be associated with a labral tear, which is a soft tissue cartilage that surrounds that socket, a bit like a gasket in a car. Next slide. Hip arthroscopy or keyhole surgery also is outpatient surgery with small incisions. It takes in the region of 2 hours to do, and it can be challenging surgery, so not all surgeons do these surgeries, and the outcomes are not as good as knee arthroscopy. Next slide. And this is an example of a fairly normal looking hip on an x-ray with a little bump there that bumps onto the pelvis that can be shaved down. Next slide. Bursitis is a common problem that I see in patients with and without hip replacements, and it tends to be that painful hip bone on the side causing difficulty lying on that side or pains. And as I mentioned, a bursa is a fluid-filled pouch that can get inflamed. Actually, the underlying process is wear and tear or degeneration in the tendon of the gluteus medius, a bit like the rotator cuff, and there can be a tear there, but if not, it really is strengthening program with some anti-inflammatories and sometimes an injection if that doesn't work. I'm a big fan of topical anti-inflammatory gels so you don't have the side effects of oral anti-inflammatories. And surgery is a last resort really, and patients don't do well. So I really will only do it once we've really tried everything else. Next slide. And that's an example of the injection which we do in the office if necessary. Next slide. Hip flexor problems really are more of a rarer problem, so I won't touch too much on it, but it can be a tendonitis or a snapping hip. And this is usually well treated with physical therapy, sometimes after injection. I put it up there because I get referred a lot of patients after a hip replacement, particularly the anterior approach, which is becoming very popular in the US and around the world, and that can lead to problems with a catching hip flexor. And I certainly see these patients from all over the place, and we treat these with therapy and injection and sometimes surgery arthroscopically to release the tendon if I don't need to change the whole hip replacement itself. Next slide. Back pain I put up there, even though I'm not a back specialist, I see a lot of it, and hip and back go hand in hand, and sometimes you can get pinched nerves causing knee pain too. And I rely on my spine specialist colleagues to help me out. And I would say to you and all my patients that it's rare that you just have back pain or just have hip pain. It's a combination of both, whether it be 50-50 or 80-20. A nerve impingement can cause referred pain down the legs, believe it or not. I'm very quick to involve my spine colleagues if necessary. And ideally, I suggest your spine is treated first before I treat your hip, just because our nerves are so important for our muscle function and walking. Next slide. Robot assisted is very common or becoming common. I've been trained in it certainly, and we're one day perhaps may have it at VCU, and it is in process. And we know that it doesn't make a difference between a surgeon putting in your hip or knee replacement or robot assisted, and the outcomes are no different, although the downside is cost certainly, and sometimes extra pins need to be put on your leg. So there is a downside to it, although increasing in popularity, and something to watch out for. Next slide. Stem cells I get asked a lot about, and certainly there's no evidence for this at present. I saw a patient the other day in clinic who spent $9,000 out of his own pocket to have stem cells injected. He didn't really see a benefit, and images like this on the internet, I would advise caution, because this is not supported by the orthopedic community, certainly in the US or in the world, and not FDA approved, and often provided by non-physicians. So it may be a solution in the future, and I think certainly we should watch this space, but certainly caution for now. Next slide. What can you do if you have pain? Well, I always say take some simple Tylenols. There it is again, some anti-inflammatories. Ice tends to work well for swelling acutely in my athletes and non-athletes, but heat is really soothing, particularly at the end of the day. Massage can help too. Some gentle exercises, just some stretching is always helpful. Some gentle strengthening if you know how, and I certainly provide knee exercise sheet or hip exercise sheet to all my patients that come to my office and try and reduce that strain on the hip and knee. Even use a cane if necessary or a brace in the case of a knee. Next slide. When do you come to see me or another physician? Well, with that slide I just showed you, most of your symptoms will get better. But I think if it's not getting better, if the pain is significant, certainly after 2 weeks of a regular anti-inflammatory, for example, then I would certainly get it checked out. Certainly you can come sooner. I'd be happy to see you. But particularly if you have a fall or if your pain is getting worse, as I mentioned, if your knee's giving out, for example, or the hip is popping, and if you're having difficulty with everyday activities, particularly if night pain. Next slide. And again, next slide. Thank you. So take-home messages, I have to finish up now. Hip pain and knee pain is very common and sometimes can be more complex. And you can expect a good history and physical exam from me. Expect up-to-date x-rays and bring your own ones in, and a CT and MRI only if it changes treatment. Often hip and knee pain can be self-treated, as I mentioned, but I always focus on non-operative treatments first, even though I'm a surgeon. That's a ladder approach, and physical therapy is paramount, or at least a home exercise program. And surgery, although I love doing it, and that's what I'm trained to do, it is still a last resort in a number of cases. And I try to preserve your joint if possible, even though I very much enjoy joint replacement surgery. And as always with any surgery, the benefits must outweigh the risks. Hip and knee arthroscopies, remember, is not for arthritis, although I will consider it in very select patients. And new technologies are always and ever emerging. I would always say be cautious, ask questions, make sure you have a licensed and certified physician providing your treatments, and make sure there's good evidence with minimal side effects with whatever you do. And I'm always proud to say that I always treat you as a member of my family and give advice as if you were as such.
Thank you, Dr. Patel.
Thank you very much.
So we hope that you're enjoying today's presentation, and would like to encourage you to download a complimentary guide to learn more about joint pains and what you can do. So you'll find the direct link to download this complimentary guide in our comment section. So we will now move over into our question and answer section. So we'll first be addressing a few questions that were submitted in advance, and then we will move into any comments and questions that you have that you added to the comment section. So our first question that we have, how soon will I be able to walk after hip surgery?
Great question. So day 0, so the day of surgery, I expect all my patients to walk, which sounds scary and painful, but the good news is that we get you up and about with excellent pain relief, and that involves not only the anesthesiologist keeping you pain-free during surgery and immediately after, the use of local anesthetic, we call it total joint cocktail, that I inject around the joint, but also adequate and very effective oral medications or tablets. And so as soon as I can get you up and walking, the better the blood circulation in your legs and feet, and we reduce the risk of blood clots. And remember, this is safe though. So definitely with walking aids if needed. If I provide any or place any restrictions on weight bearing status, then these are made very clear. And there's a whole host of therapists to help you do that, and sometimes even bracing, although I often don't need bracing for most of my surgeries.
Oh, that's good to know. Our next question, after my knee replacement surgery, is it normal to hear clicking in my knee joint?
So for for hip replacements, no, it's not normal. And the hip joint is a smooth ball and socket joint, and the replacement itself should not be making any squeaking. Sometimes that can happen with ceramic bearings or if something is rubbing on another part. And definitely come and see me or get that checked out for the hip. For the knee, I get asked this a lot, and it can be normal to hear clicking in the knee joint. And that's because the knee is a very basic hinge joint. It's like a door hinge. It's a very fancy and expensive one that's going to last you a long time, admittedly.
Mm.
But when that metal hits the plastic in certain positions, or the kneecap runs over the metal, the plastic part, then there can be a clicking. And as long as there's no pain or swelling or the knee
Okay.
giving out, then it can be normal. But any of those symptoms, then definitely get it checked out.
Okay. Thank you. And then next question, will my new replacement joint, knee or hip, set off airport security? Or do I need to carry a travel card to let TSA know that I've had a replacement surgery?
Another great question. I get asked this a lot. So as I mentioned in the talk, 1 million joint replacements are done in the US alone. That's a lot of people, obviously. And yes, the joint replacement will set off the alarm. It's
Okay.
cobalt chrome and titanium alloy, state of the art, but still a very tough, strong, and dense metal. Um,
Right.
Sadly, the days of carrying a letter from me or a joint replacement card are gone, and particularly sadly in light of airport security restrictions, um, there's only one way really to get past the scanner, and that will be to have the total body scan. Often patients will just opt for that.
Yeah.
Other times you can show your TSA official your scar, obviously keeping decent if possible,
Right.
and indicate to them that you have a joint replacement. But certainly be upfront with the TSA team. They're very well aware that many people have joint replacements, and it may be that you just have to pop into that scanner, sadly, and get you through security.
Okay. Well, thank you. And then the next question, what activities should you avoid following a hip surgery? And I know you touched on this in your presentation, but maybe we could just do a quick run through of them.
Yeah, absolutely. I would say um, for my joint replacements, it depends on the approach I use. My go-to approach, I do slow my patients down a little bit by asking them not to bend over and pick up things,
Mhm.
not to cross their legs, just for a few weeks, just to slow them down and allow the tissues to heal. That
Right.
still means that they can function really well. And as I mentioned, some are back to work at the 2 week mark, back in the gym at the 4 week with low impact exercise, even running. So all those activities are still very much possible. I always recommend low impact exercise lifelong to preserve the joint replacement, because theoretically it can wear out sooner, but doing it to get your life back and be able to do all the things you love. So,
Right.
it's always the patient's decision. But beyond those few weeks, no restrictions.
That's good. And then the next question we have, what percentage of total knee replacement is done using robotics?
Yeah, good question. And I think when it came out over the last 5 or 10 years, when I was on fellowship 5 years ago now at least, it was just coming out and becoming popular in the mainstream. So around then it was maybe 10, 20%. I don't know the full figures across the US and the world, but we know it's a good, probably approaching, if I were to guess, at least a quarter of all knee replacement, at the very least, 25%. Um, it is increasing to a degree because of certainly patient demand and
Right.
the belief that robotics can improve the knee replacement you get, but not at a massive scale, because that has not been shown in the studies. Having a
Right.
robotic knee has the downsides of extra pins and a longer procedure and extra cost. And at the end, when we put a knee replacement or a hip replacement done by a surgeon with and without a robot, we know that ultimately there's no difference. So
Right.
it's a growing number, I would say, and watch this space.
Okay. And just to ask again, if there's any additional questions, I'll give a couple of seconds to see if there are any more.
Great.
All right, well, it looks like those are all the questions that we have for tonight. Dr. Patel, it was such a pleasure having you join us for this educational webinar, and I'm glad that we had the opportunity to discuss how joint replacement surgery can be a good solution for those with hip and knee pain, in addition to more treatment options available depending on what the issue is. So to learn more about Dr. Patel and orthopedics program at VCU Health, please visit vcuhealth.org or follow VCU Health on Facebook. Also, make sure to download the helpful complimentary joint replacement guide. The link will be available in the comments below. And once again, thank you, Dr. Patel, for joining us. And to everyone else who joined, have a great night.
Thank you, everyone. Thanks for your time. Thanks, Shanice and team.
Of course.
Bye-bye.